Hello, everyone. I'm Ron Rolfing, your host of the ACAP Preferred Vendor Education Series, and I'd like to welcome you to our latest session presented by Alera Health. Our presenter today is Mike Rhodes, CEO of Alera Health, and he is presenting From Integrated Care to Integrated Systems of Care, how value-based contracting is evolving to include behavioral health. But before I turn it over, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's call, and we will post the slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. You can also post an inquiry, an RFI, or an RFP on the preferred vendor connection portal. And that link can also be found on the preferred vendors page. And of course, during today's session, you can ask a question at any time by clicking the Q&A icon in your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now, I'll pass it over to Mike to get us started.
Thanks, Ron, and thanks everybody for sharing your lunch hour with me, or I assume it's your lunch hour. I have had the pleasure of doing webinars for ACAP in the past, and Ron, just kudos to you. It's always professionally organized and run. You know how to set these up and run them like clockwork. So thank you all for hosting us today. I want to welcome everybody who is joining us today on this topic. A couple of names I know, so thank you guys for joining. And really what I wanted to do today is really talk about how behavioral health is evolving into managed care strategy. It's a solution to not just improve performance on total cost of care and quality measures, but it's a differentiator in bids. It's a differentiator in partnerships. And I wanted to share how you might harness that within your health plan, but also talk about how those behavioral health CINs can convert themselves beyond just being a siloed group of behavioral health providers working on behavioral health issues, but how they can morph into these integrated systems of care. As all of you know, integrated care is not a new concept. It's been around for about 20 years now, and there are pockets of success at the provider level, when particularly in urban or dense areas where there's enough volume and complexity to support co-located staff, both behavioral health and primary care and specialists. There's the FQHC models, and now there's the CCBHC models. The challenge with those models is, while they can be excellent, they aren't necessarily scalable, particularly as you get into suburban and rural areas. And that leaves gaps in your network and complexities, because you end up doing it a lot of different ways with every provider or every system you come across. So I really want to talk and focus a little more on how you take the principles of that and bring the system of care together using those value-based contracts and how that can help you. So, well, with no further ado, I'm going to try to make this fun and engaging as we go, because nobody wants to spend their lunch hour just hearing drone on and on. So I'm going to have a few case studies and personal stories to connect some dots, and hopefully that'll be engaging. So for those of you getting on the call, wondering when you're going to get your sign, here it is. And I do that a little tongue-in-cheek. The world of medical reimbursement will soon end as we move into pay-for-performance contracts, shared savings, global cap, Prometheus budgets, bundled payments, the word salad that is value-based contracting. Many of you are playing in this, or at least dabbling in pay-for-performance contracts if you're not moving into one or two-sided risk contracts. Recognize that, much of that work thus far in the industry has been very primary care centric, which makes sense. If at the end of the day, you need somebody to be the quarterback of the care, why not the primary care doctor? over the last 5 years or so, there's been an evolution in thinking that certain populations who maybe see their primary care doctor infrequently or are difficult to engage, which is a fancy word of saying they don't show up for appointments because they have a lot of other obstacles to care, that maybe we need to take a different approach with those populations or run the risk that they'll languish out there and drive up costs without necessarily being fully engaged. So why behavioral health? These two data points I think you'll find interesting. 38% of our ONEcare patients have a secondary chronic health condition when they're attributed to our ONEcare networks. When they're attributed, only about a fifth of them will actually see their primary care in that given year or have a history of seeing their primary care before we get to them. On the flip side, when we work with our primary care partners, about a similar amount have a secondary behavioral health issue. So these are primary care patients with a secondary depression, anxiety, substance use disorder. Only 12% will see a psychiatrist in that same year. So what we have is this kind of, we call it silent suffering, right? The disease exists, it's documented, yet there's no follow-up, there's no coordination, either on one side of the house or the other. So here's your huge opportunity to bring those two sides of the house together and get them talking and connected. What does that mean when you have these polychronic medical and behavioral health conditions? It translates to about 4 times more in total cost of care. Nationally, about 188 billion in avoidable healthcare spend, according to NAMI and several studies. That translates, if you're sitting there thinking, why should states or why should Medicare care about this? Just a little shy of 2% of our GDP. But most importantly, from a human perspective, it knocks about 25 years off of life expectancy for this population. So they're very expensive population, and they drive a lot of social policy, they drive a lot of medical policy. But I want you to see that red arrow in the data in there when we talk about reduction in life expectancy. One of the more shocking rises that we're seeing in our data is the rise of suicidal ideation, and it's not just relegated to kids anymore. We're seeing it in geriatric patients, we're seeing it in adults, women, children, all races and genders. And it really has had a lot of hyper focus in the child area, but it is not necessarily isolated to that subsection as well. So why are behavioral health patients with behavioral health disorders unique, right? Why do they need extra attention or focus? Well, from a patient perspective, they're not just seeing their primary care doctor once or twice a year. They're also seeing behavioral health providers and specialists, and they're in and out of hospitals. And every time they go into an emergency room or a hospital, hopefully they're being reconnected with their outpatient care team. But more often than not, they're not always the best reporters, or they have a deference proclivity where they are deferring to whoever the doctor is in the room, saying, well, if you think I should go to a new clinician, I'll go to a new clinician. And what that ends up doing is continually breaks those relationships and resets those. And it can lead to multiple providers, even multiple of the same type of providers. They can have 2 or 3 primary care physicians that they're seeing, and they never really settle in and find trust with one. They can bounce around between psychiatrists or therapists. They can bounce around between different outpatient or community outreach programs or specialists, and that gets very complicated and confusing for them. More often than not, they're on multiple medications, right? And it makes sense, right? They've got anti-anxiety medications while they also are on medications for their COPD. Translate that, the psychiatrist may or may not be talking to the primary care and vice versa. If you're going in and out of the hospital, that's another opportunity for the meds to be reordered, and new medications could be added, and not necessarily does any of the care team know that, which fills up a medicine cabinet. And I'll show you an example of that in a second, where the medicine cabinet fills up with active meds from multiple sources where no one is really coordinating between one another along there. Some of the biggest challenges are still at the very basic stigma and embarrassment. I don't have that disease. You must be talking about somebody else. I'm not depressed. I don't have a problem. How would I possibly admit this even to my spouse, let alone my friends or my colleagues or go to a support group. I don't even want to be seen in the waiting room here. And then behavioral health patients see a higher propensity for health-related social needs, right? That behavioral health disorder, the drinking leads to job insecurity, which leads to housing insecurity, which leads to transportation insecurity, childcare insecurity. All of that full circle rolls around to, I can't make it to that appointment. I don't have time to coordinate that follow-up care or follow the eating plan or nutrition plan. And so now I'm back in the hospital, which disrupts that care over and over and over again. But there's also a recognition that there is challenges on the provider side, right? Those same providers who may be doing a yeoman's job of trying to coordinate beyond the behavioral health care, beyond the primary care, are operating with extremely limited information. I can see what's in my EHR, but I can't see what in somebody else's EHR. And all I got was a piece of paper that a patient's being referred to me, or maybe the patient was walked up to my door, made a phone call and said, I was referred to you. And the only thing I have is whatever the patient reports to me in that moment. Go back to that stigma and embarrassment. The patient is not always a forthright reporter. They walk in, they share part of the story. If anybody ever watched House MD, you know, the patient always lies. And that may or may not be true, but that stigma and embarrassment does challenge accurate reporting in the clinical setting. That same multiple provider thing gets complicated. It gets overwhelming. And so the primary care doctors can reach out and coordinate with one provider. But what happens when there's 4 or 5 or 2 hospitalizations in the last 2 weeks or 2 months, right? There's only so many hours in the day. It gets overwhelming. I've done the best job I can, right? I'm not a care manager to keep all the track of all this, but I've done what I can here. And there's also a misunderstanding and stigma within the provider side, particularly the medical community around behavioral health. We really try to, we're not equipped to manage behavioral health, which can sometimes be code for, I don't want to get a call on Saturday night at 2 a.m. because my behavioral health patient is in the emergency room. I don't know how to deal with that, right? I have extreme liability if I'm prescribing antidepressants and I'm not equipped to do that. At the hospital level, they show up in the ED. Just get them referred over to an inpatient psychiatric facility and let them sort it all out, right? Which drives up costs. It tags you in EMTALA rules. It increases complexity, and it goes back to multiple medications, multiple providers over and over again. But the biggest challenge is these patients don't always show up for the appointments, right? It's not uncommon to see 60 to 80% no-show rates within this population for primary care visits and behavioral health visits. And so at some level, if the patient's not showing up, well, I'm not going to go find them. Well, that's fine when you're in a fee-for-service world where you get paid for people showing up. It doesn't work in a population health management world where you get paid for the health outcome, whether or not they show up. And part of your role is to engage them at their level, not making them engage at your level. So all of that, and we have these silos of care at the system level. The medical doesn't traditionally work with behavioral health. Behavioral health providers compete and don't always communicate with one another. There's not necessarily the incentives driving those parties together, incentivizing partnership. There's a focus on that treatment over prevention. And then nationally, there really isn't a drive to do that SDOH assessment and mitigation. So oftentimes that's left out of the diagnostic profile. So all of this translates to higher costs. So I want you to take a really good snapshot in your mind of this graph right here. This comes out of AHIP. This is the categorical spend of medical services for the general population. About 22% on prescription drugs, a little less than 20% on inpatient hospital costs, 19, almost 20% on those professional, 3% on those emergency rooms, 11% on those doctor's visits. And then way down at the bottom, that other outpatient care, which lumps all other outpatient care, including behavioral health, 6%, right? So behavioral health is just a tiny fraction of that. So let me click a button. I want you to burn this into your brain for just 1 second. And now I'm going to click this button. Here's what it looks like for patients with a behavioral health condition. And I'm going to go back. Look at that difference between the prescription and the inpatient drug costs. Prescriptions moderately higher, but look at that inpatient hospitalization cost, right? That's really what we're managing down. Unnecessary inpatient utilization because we're not coordinating the front end. We're not engaging those patients. We're not putting the time in on the front end. And rather, we're waiting for them to show up in the emergency room saying, wow, I wish somebody would have done something earlier. We could have avoided that. And this is that sign. This is that moment of how do we do something earlier? We don't really have a behavioral health problem in America. I'm trying to emphasize we have an engagement problem in America. Once we get them engaged, we have the medications, we have the therapy, we have the tools and techniques. But if they're not engaged, they're not showing for appointments, if they're not excited about showing for appointments, if they don't see value in those appointments, right, then they're not going to get better. And again, in a fee-for-service world, we can shrug it off, but in a value-based world, we cannot. So let me put a face with this. And as you guys know, I can't tell you a story and share pictures of an actual patient, with the exception, I have the permission to share the story of my father. So this is Mike Rhodes Sr. And for those of you who've seen my face on the screen right now, yes, we are genetically related. I know that's a stunner. And for those of you who think he's quite the hunk in 1968, I'm sorry to say he is decidedly off the market. But my father, I like to share this picture because he was an extremely proud man. He was athletic, he was physical, he was active. This is what he envisioned his best self being. As he aged, he started a family young. He was a very proud father. We camped, we fished, we were outside all the time. He did all the healthy things a healthy father would do. He had a blue collar upbringing and lifestyle. He was a truck driver. He was a tractor driver. He was a man who worked with his body all of his life. And as he aged, some of that muscle turned to fat. And some of those injuries from football in his youth and weightlifting started to catch up with him, started with knee problems, turned into hip problems. He would go to doctors and get bounced around to various specialists. And then I would call him later and say, what medications they put you on? He says, I don't really know. I didn't, I didn't really pay attention. It was too much, too confusing. So I take a lot of ibuprofen. I learned later he was taking 8 to 12 pills of ibuprofen in a single sitting 4 or 5 times a day. What I didn't know then, what he didn't know, is that he was slowly poisoning his kidneys. And so later in life, he would end up with end-stage renal disease level 4, which shut down his kidneys. Prior to that, diabetes set in, heart disease, congestive heart failure. One of my most, and then the complexity of his care got more and more medications in the medicine cabinet. And he was starting to go in and out of hospital, so that by the time it's 2018, this is what my dad's lifestyle had been reduced to: non-ambulatory, mostly sitting in a chair, which was a far cry from where he began. It is not the vision of what he wanted to be, but it is where he ended up at 69 years of age. When I got involved really in 2016, 2017, his care had gotten so complicated. And keep in mind, he's 2,500 miles away from me in South Dakota, and I'm in North Carolina. His care had gotten so complicated, it was overwhelming his wife. He had no care manager. He was seeing 13 different clinicians on a regular basis, prescribers. He was trying to move back and forth between South Dakota, snowbird between South Dakota and Florida when he could. So he had prescribers in different cities in Florida and South Dakota. He was withholding visits to certain specialists until he got back from his snowbird trip. He was in and out of hospitals. When I got involved, he had 23 active medications on his active med list, and he had 61 pill bottles in his medicine cabinet and on the drawer. At that point, he didn't know what to take or not to take anymore. In his last year of life, he had roughly 12 medical appointments a month. He had 4 emergency room and inpatient visits for a total of 74 days in the hospital. 3 of those visits ended up with rehab stay afterwards for a total of 97 days. He had been diagnosed in 2017 with depression. And yet for 2 years, we were unable to get him to see a single psychiatrist, therapist, clinician, because there simply was no access in Rapid City, South Dakota for him to see a therapist, even virtually at that time. His last year of life translated to about $1.2 million in total cost of care. All the while, his life had been reduced. He had housing insecurity. He had a house that was not equipped for a wheelchair, that required Hoyle lifts to move him from the bedroom to the bathroom. He had financial insecurities that made it hard for him to afford the meds, transportation limitations, and quite frankly, they lived in a food desert, right? They were, roughly 25 miles from a grocery store. Leaving him alone was not an option. And so they didn't have any professional care for him. So oftentimes his wife ran down to the Quick Mart to get a can of Dinty stew, and that was the dinner for the night. So I just wanted to put a face with a name. What we're talking about is not your severe mental illness, schizophrenia population. It's our dads, it's our brothers, it's our mothers. That's who we're talking about here. And there's real opportunity for us to do better with that. As I like to say, cars ain't people. We can't put them in an assembly line. We have to fit each one of them and wrap them around with all those experts who can support them as a true care team. We have to build cars like we used to, and we have to rebuild people from that same perspective. So let me give you, I'm going to close this out here. Let me give you a little bit of language that oftentimes gets confusing out there. All of you all have heard of accountable care organizations. These are typically, if you're really being technical about it, they're referencing the CMMS MSSP, I'm sorry, the CMS MSSP, Medicare Shared Savings Program. Technically, CMS owns the trademark to accountable care organizations. So in general terms, we talk about ACOs as clinically integrated networks. The difference around a CIN and ACO is they typically are about bringing like providers together into a network, but a siloed network of similar providers, all roughly doing the same thing, right? And so they're taking care gap reports and they're all going back to their corners as individual primary care docs or behavioral health providers and trying to close those care gaps. And then they check in on each other on a regular basis. Maybe they share some light best practice. But at the end of the day, they're staying in their lane. They're doing what they're most effective and comfortable with. They're not really harnessing the power of a one-to-many connection as that CIN to negotiate relationships with specialists or hospitals or social care organizations. And so therefore, the industry is starting to use a more refined term to describe a higher level of CIN, and we call that an integrated system of care. This is where you take a group of like providers into a CIN, you reach across the aisle, and you start to develop these multidisciplinary systems of care. So the behavioral health providers negotiate a SIN-to-SIN relationship with a primary care SIN, or they reach across the aisle and they develop a high-value collaborator agreement with a local hospital system where they're helping to divert behavioral health patients away from the ED, get them out of the ED quickly when they do show up there, or the inpatient setting. In exchange, they want to co-locate staff, they want to share data, they want to share clinical workflow and documentation workflow so that we can quickly move that patient out and there's no bureaucratic red tape to moving them back to the lower level of care. And ultimately, at the end of the day, you want to build trust around the involuntary commitment process. If the hospital is knee-jerking patients from the ED right into an inpatient psych, how do we give them an alternative around a structured discharge step-down plan so they can say, I'm comfortable stepping them down as long as they're going to get access to an appointment within 24 hours. They've got a peer support or a transitional support staff who will follow them out of the hospital, follow them home, address that food issue, and make sure they get to appointment the next day. When you start to provide that level of structure, you're starting to provide a solution, but it requires a broader network than just a silo of behavioral health providers. What it is not, and sometimes gets conflated with, is an independent practice or an independent provider association. That IPA structure is designed to come together under a messenger model to negotiate solely fee-for-service contracts, right? A CIN allows, and an integrated system of care allows a broader clinical integration, the data sharing, all designed to lower costs and improve health outcomes. What they get in exchange is the ability to collectively negotiate with the payer and say, let's negotiate a contract which incentivizes the entirety of the network, not just individual members of it. And that's important for you and not something to feel threatened by, because you're going to use that big carrot to drive that network in the direction you want to go, to focus on the health outcomes you want them to focus on the savings you want them to focus on. They're going to get paid their fee for service. But at the end of the day, the big carrot, the big bonus is around improving outcomes and performance. So I just show you this to show you the translation. You know, this really started firm in 2010 with the pioneer ACOs. It moved into Medicare shared savings, really was the launch track for ACOs and CINs. You start to see this influence of specialty networks of care when you get into the next gen ACOs and ACO reach. You're starting to see Medicare say, wait a sec here, there's a lot of primary care stuff going on in these MSSPs, but we're not seeing those MSSPs bring behavioral health or specialists to the network. So we're going to give them more flexibility. We're going to give them more incentives and authority to try to pull those things in and try to build these blended ACO models there. About the same time, you're starting to see commercial contracts start to show up. And then Medicaid shows up in late 2018, 2019, really looking at that primary care health home, but moving quickly to that specialty health home, which makes sense because within the Medicaid population, you have a 70% co-occurrence of that behavioral health disease. And so they quickly moved to focusing on those specialty health home models. And now you're seeing CMMI and Medicaid start to experiment around the innovations in behavioral health home. And these are direct attribution models for shared savings contracts. And they're applying those around the US. So there is a movement afoot, and that all signs indicate that's going to continue to expand over time. So why not just go out and work with individual providers, right? And a little bit, I'm showing you the provider perspective on this. Behavioral health providers are really where primary care was in 2010 to 2015, right? This is a brand new concept for them. They're really never been fully exposed to population health or value-based contracting. It's an extremely steep learning curve. It's not uncommon for a CIN to put $15 to $20 million in the technology and the staffing, in the data aggregation and analytics just to get it off the ground, and then be operating an admin budget of $3 to $5 million a year just to keep the lights on in there. That's not even earning money yet. That's just making sure that the system is, the CIN is operating. A big challenge is there are very few subject matter experts out there. We don't yet have an education system that does a master's in population health. And so consequently, we have to kind of apprentice and train our people in the industry, which means that the larger aggregators like us, like Aledade, like Evolent, they tend to be the loci of those subject matter experts, and it's really hard to find them at the local level. Another challenge is this is a whole business in and of itself. The complexity, the negotiations, the knowledge set that you have to have. And for many providers, they got to operate their day-to-day job. They got to keep the team working within their clinics and their programs. And so if they allow themselves to get too distracted, there's a real risk that their primary business will start to falter. And the last thing I'd leave, and this affects you as much as it affects as MCOs, as much as it affects providers, is the small N sensitivity. We're not talking, when you're talking about an integrated behavioral health system of care, you're not talking about hundreds of thousands of lives across the state. You're talking about anywhere from 500 lives to 3,000 lives to maybe 10,000 lives if you're really big, right? Probably about 10% of your total population would be eligible for a behavioral health CIN model. When you start to get really small numbers like that, one patient has a tremendous outsized influence on the performance, on a quality measure, or on the cost of care, and it creates this high sensitivity that starts to waffle the performance of the network year to year, month to month, and it's very hard to really get your arms around how are we doing and are we incrementally improving. And then last but not least, a single provider, well, no matter how big they are, unless they dominate the entire state that you're in and they're the only behavioral health provider, when they go to knock on the door of a hospital or a primary care CIN and say, hey, I'd like to work with you. I'd like to collaborate. I have this referral system I want you to use. I have this data I need from you, and I'll share data back with you. And there's some things I want you to act upon when I share this data with you. Chances are they're not going to get through the door, right? Because from a hospital's perspective or a health system's perspective, I could work with you and you may be great and all, but there are 15 other providers just like you doing behavioral health services in my community, and I can't do this 15 different ways, right? So until you guys get organized, I'm not going to work with any of you. And so the leverage that you get in coming together allows you to build partnerships that you wouldn't otherwise have. When you build within an integrated system of care, the CIN, you can share knowledge, you can share cost, you can time share that cost. You have that one-to-many leverage, less sensitivity on your smaller ends because you're spreading those lives across all of the network. All of the network is bringing lives to the table, which makes a bigger number. And it allows you as a provider to govern the network because all of our CINs are provider governed. Alera helps manage them, but at the end of the day, they're on the board of directors. They lead all the CQI committees. We help facilitate all that. So the end goal is we're stronger together, which creates an opportunity to earn a bigger carrot. And before you say, well, that's just the provider carrot, remember, in a 50-50 shared savings contract, half that carrot is the providers, half of that is the MCOs. And so we're all rowing in the same boat. You want your CIN to outperform other CINs. You want it to outperform your past performance. And you want to point to that when you go into your next Medicare or Medicaid or duals bid and say, look at what we did around behavioral health. Nothing more than how we negotiated contracts and incentivized that network. We gave up nothing. What we did is we delegated responsibility. We helped them organize into this network. We supported them from a clinical perspective, and look what they accomplished on their own with our support. That's what you want to point to in your next bid. So just real quickly, who we are. I'm Mike Rhodes. I'm the CEO of Alera Health. We build and manage integrated systems of care for patients who have a primary or secondary behavioral health network. Behind that, we do everything from soup to nuts. We support the setting up the LLC, to the governance, to the negotiating the APM agreements, to the participation agreements. Then we support all of the quality improvement activities. We also do all the data and technology infrastructure behind the network, including our clinical intelligence engine, which is our data aggregation and analytics engine. We have our link care coordination engine, so that's electronic referrals, care navigation support, network surveillance. So we'll know within a week if we've got a gap in the network where we're missing a service in a specific geographic region, rather than waiting for complaints to come through 8 or 9 months later. We have a care information system and a care management information system, both where you can see past patient history, open care gaps and alerts on that patient. You can see care management notes. You can see care management plans in there. And then we have a mobile app, our One-Touch Remote Patient Engagement mobile app, where we can do wellness checks on the patient. We can push out health literacy information that's curated with their disease profile. They can schedule and reschedule appointments, and it has a button where you click on it and they can be automatically linked to a mobile crisis management team virtually, who can then try to stabilize the patient if they have a behavioral health issue while they drive out to the patient to avoid that unnecessary ED visit. Just as a case study, in Arizona, we've got 2 regional ONEcare networks together They support 35,000 severe mental illness and what we call general mental health and substance use. These are patients who have a chronic health issue and a secondary behavioral health issue. Total spend on that population, $824 million last year. We reduced the MLR by about 9%, which saved about $75 million in the total cost of care. And you can see the categorical improvement of the HEDIS measures there. There is a lot of room for improvement with the behavioral health population. Right now, they're largely unmanaged across the nation. So every state in blue, we have active ONEcare networks. We have contracts with payers in those markets. Every state that's either orange or yellow are states where we are actively assembling ONEcare networks. That means we got at least one payer in those markets who has indicated if you build it, we will contract with it. That does not mean we're not interested in the gray states. It just means that we have yet to be contacted and said, hey, if you build it, we'll contract with it. So if you're in one of those gray states or orange states or blue states and you're interested in this, we would love to talk to you. Our goal today is really just to educate you on how to move beyond the CIN or the ACO into those integrated systems of care and how you can harness that for your most complex and challenging behavioral health population. Oh, one last thing. For those of you who are on the phone who said, God, that's a lot of stuff to digest, and I would really like to get into the weeds on that. We this year partnered with Open Minds to develop the ONEcare Population Health Academy. It is actually launching in October. You see that there's a website there. It's supposed to go live next week. But if you memorize this and go down there, if you're interested or you have staff that are interested in really going deeper into the background of population health and value-based contracting, the legal compliance issues, and building a CIN, how to organize those networks, APM contracting with the integrated system of care, data quality. If any of that is interesting to you, it's free for Open Minds members and any other guests, like guests from ACAP who want to join. We can give you a code and let you join. But we would love for you guys to join us here. Our goal is just to educate and get people excited about this concept as a field and start thinking about how to harness it within your MCO. All right. I am done. My contact information is there. I'm going to hand it back to Ron and see if there are any questions or commentary. Ron, are you with us? Wow. Let's see. You're muted. Can't hear you. I see you. Kim, can you hear Ron?
I could not.
Okay. I can hear Kim. I just can't hear you, Ron. Uh-oh.
I did have a couple of questions that came through. If
Now
you
Did
want me to, whoop,
you can hear me now?
There
yes,
we
we
go.
can.
Now we can hear you, Ron.
Okay,
Okay.
sorry about that. Just hung
No
up there
worries.
for a second. Bluetooth is a wonderful thing. Our first question, just a reminder, if you have a question, click on the Q&A icon and type it in. In your experience, what are the key drivers for the higher inpatient and crisis utilization by the behavioral health populations?
Yeah, it's a good question. It's kind of what I was talking about earlier when the complexity of that. It is a more behavioral health is both a disease and a driver of outcomes. If you can think of it that way, it's a disease of the mind, and it requires treatment, and there are methods for treatment. But also it's an influencer on how people engage in their other healthcare, right? The diabetic, like my dad, who was unmotivated because he was depressed. And I'm ashamed, I meant to say this. I'll just take a moment to say this. Here I am in the industry. I've been doing this for 30 years in behavioral health. And when it came to my dad, with my own stigma and embarrassment, I didn't even dawn on me that maybe my dad is depressed and that's why he's not taking his meds on a regular basis or not taking care to make sure he's taking the right meds, right? I judged him for it. And I'm embarrassed to admit that I should have known better. But that's my own bias in that I didn't want my dad to be depressed. I wanted him to be a superhero, right? But in reality, he was. And it was a third party who said, have you ever considered getting him evaluated for depression at 68 years of age? Duh-huh, maybe I should have thought of that. And then it all made sense, right? If he wasn't motivated, if he looked at his life and he's non-ambulatory and he is not the man he used to be, then why am I even living? And in some ways, he might have been a slow path to suicide. Let's end this quickly by not taking my medications because I see no purpose in all of this. And so I would say that that's what I'm trying to illustrate, that it's an influencer of how people engage in their medical care as well. And then the snowball flows downhill from there and is logical, right? If I don't take care of my diabetes, then I'm going to end up in the emergency room. What is the proximate cause for ending up in the emergency room? Not taking the insulin or some type of diabetic coma. But nobody's saying the proximate cause is you were depressed and so you didn't take your meds. That's what we see when they show up in the ED was the causation related to the diabetes. So I'll stop there, but that gives I think that's part of the complexity that we deal with in behavioral health.
Okay, our next question. What is an ideal population cohort for a ONEcare network?
Yeah, I don't know who asked that. It's a good one there. So I said earlier, in general, it's probably about 10% of the general panel is what we found over the years. And typically what happens when we're brought in is we'll ask for a 2-year claims file, de-identified of all your population, and we'll come back and we'll suggest who might be eligible for ONEcare. And what we're looking for is, one, they have a severe mental illness, right? And or they have a chronic health issue, and they I lost my train of thought. They have a chronic health issue, and they have a secondary behavioral health issue like depression, anxiety, or substance use, and they show no history of engagement with their primary care in the last year, and they've been in and out of the ED in the last year, right? So what we're looking for is something that reflects that this is a population that has needs. It fits the profile of behavioral health and chronic health issues, and they're not engaging with primary care for whatever reason. And that's not a judgment on primary care. Many of these patients were enrolled in Medicaid and we had contact information, and a day later they moved across town and nobody's even they don't even know who their primary care, and so their view on that is, when I get sick, I'll go to the emergency room and I'll get the Band-Aid and I'll feel better, and then I'll go back to my life, not even recognizing that there is another alternative to start engaging with that care team before they lurch from hospital visit to hospital visit. So a lot of times our work is doing that community outreach, finding those patients, having that conversation around what if we get you in and do some medical screenings now, some behavioral screenings now, see if we can't get you stabilized on your meds, make sure you get those meds on a regular basis. We'll do routine checkups with you so that you don't have to lurch from disruptive hospitalizations to hospitalizations. And that's not 100% guaranteed. Just because we find them doesn't mean that they always say, yeah, that sounds great. For some of them, it's just like, no, I'm fine right now. I'll see you at my next ED visit. But all you got to do is win over a few souls, right? And these are people that are spending, $3,000, $4,000 PMPM, right? If you can win over a few of those, you can have an outsized impact on total cost of care.
Okay, our next question. What is the minimum number of lives to be attributed under an APM agreement with your network?
Yeah, another great question. ONEcare networks, I'll just speak for us. We go into a market, and while we have early adopters, and those early adopters oftentimes write us into their Medicaid bids and promote us, But once we get up and running with a ONEcare network, we work with all payers. And there's a reason for that. Because we deal with such small numbers and small ends, in order to build a big enough panel size, we need to work with all the payers on the market, not just one or two. And so what that means for you is we can take smaller numbers, right? You know, we've worked with some very small plans that bring 1,000, 1,500 members, eligible members to the ONEcare model, and they're like, wow, this is hardly enough to even write a contract over. But I mean, these 1,500 members are costing us a lot of money. Anything you can do. Yes, because what we're going to do is roll them into our larger pool of lives that we're managing, which could be 50, 60, 100,000 lives. And while it may not be creating the biggest payday for the network, we're already doing the work. Why not do the work for those extra 1,500 lives as well? Doing the community outreach, doing the transitional support, doing the data and analytics and looking for those care gaps. It's an incremental, very tiny incremental cost for us to do the same work for another population on top of that. And so that spreads the load from we can spread that risk across the whole network, as I was talking about earlier. And then there is an administrative cost to running a network like this. And just as providers are time sharing into that, we oftentimes build in some modest care coordination fees, and then you're paying a tiny fraction of the total cost of the network, rather than trying to build it on your own. So I guess my takeaway I'd leave you with is, if you're a smaller plan sitting there thinking, I really love this, but this sounds like something that the Uniteds of the world should do. We're too small to consider that. Talk to us anyway, right? It's very possible that we're already got 3 or 4 MCOs ready to do an APM agreement. We've got critical mass on a contract, and your lives would be a great tuck into that. And it gives you a story to tell, and how you led and how you supported that. And then spend your time thinking about how your nimble, flexible health plan can do creative things in partnership with a ONEcare network, right? That's really what you're going to differentiate, is how you are contributing to benefit design or management to fully harness that ONEcare network in your area.
Okay. Well, that looks like it takes care of our questions for today. With that in mind, I'd like to thank all our attendees for taking time out of their schedule to join us. And I'd like to thank Mike for a very informative webinar today. Just a reminder that the slide deck and recording will be posted on the ACAP website by tomorrow morning. So thanks a lot and stay safe.
Thanks, everyone.